I think gastroesophageal reflux, of course, is the cause of Barrett's, and therefore it's very important and very much linked to how you assess Barrett's esophagus. What is it? How can we prevent evolution? And the technologies we will briefly cover here, but mostly cover in a lecture later on today. I think you have to be able to classify gastroesophageal reflux disease, and if you can't, it's going to be a problem. I think that you can do that using the LA classification, and it's quite a nice classification, and it's quite easy to use. We have multiple other resources to do that on GIEQs, so I'm not going to go into that now. It's just to say that, one, this is the cause of Barrett's. Two, if this is present, your assessment of Barrett's is going to be limited, and you must make a plan to bring the patient back to properly assess their Barrett's. Should we take the standard population and do gastroscopies on them? I think the evidence is clear on that. No, we shouldn't. There are, I mean, we all know them, right? We who do Barrett's know the type of patient that has Barrett's. They are white men who are overweight, who drink and smoke. I just said that without looking at the slide because I was picturing the patients who are coming here for Barrett's dysplasia, right? Should we screen those patients? Well, okay, I still think the evidence is out on that. I think there are better options. We'll come on to that. But these are certainly the patients who they also, very importantly, they also have silent reflux, these patients, right? Mm. So these are not the patients coming to the outpatient clinic with reflux esophagitis symptom. Mm. These patients don't present, right? 50% of them don't. So they don't present with reflux. They present with screening or for some other reason they have a gastroscopy. So maybe actually it's like the worst of all worlds. The precursor lesion is not symptomatic in the patients who get cancer. And so therefore, indeed, some sort of screening is interesting. Is gastroscopy the answer? I don't think it will be for very long. I think this will be the answer. And so you have non-endoscopic technologies, sponge. I think there's a clear message from sponge. If you're interested in sponge, watch GIEQs 5, Rebecca Fitzgerald, in the Barrett session, where she presented a fantastic presentation on the current status of sponge. Cider sponge is the technique I think they're using, Andrea, is the one that's coming out of Cambridge. I mean, 10-fold higher rate of diagnosis of Barrett's esophagus compared to just randomly doing a gastroscopy if the patient has reflux. And we now maybe understand a bit why that might be. There are other technologies. One of these is going to disrupt the performance of diagnostic gastroscopy in the near future. I think it's a nice slide from ESGE. The most recent updated, I encourage you to read this. Prof. Worston and the other group co-authors of this, they're really into Barrett's, and I think it's a very nice document and very nicely written. So if you find less than 1 centimeter of columnar epithelium, no biopsies, no surveillance. If you find Barrett's esophagus of more than 1, but less than 3, random 4-quadrant biopsies. If you find more than 3 and less than 10, random 4-quadrant biopsies, but we should be referring to an expert center if there's any dysplasia. That's also the case here. And the surveillance interval changes. So this group has 5-year surveillance, and this group has 3-year surveillance if no dysplasia is found. And if it's more than 10, they should be going to expert center anyway. They should get surveillance endoscopy every 1 to 2 years. And of course, if there's something in that, then you need to go to a reference center. If you find a visible lesion, you should describe it and refer it immediately. But if you have one, please use it in conjunction because I think it can be helpful. But do not neglect your own education for AI and rely upon it because I think it's not there yet. John, you have a view on that? AI and Barrett's?
I mean, AI is the future. It's just not what we call ready for prime time yet. I think it is coming, but at the moment, I think it's important that you skill yourself. I think equally important, David, is that although AI will come and definitely support our clinical decision making, it doesn't preclude you or stop you from having to learn this stuff yourself because it will be a tool and an aid, but the clinical decision will ultimately lie with the clinician.
Yeah, that's critical, I think.
Yeah, so with PPIs, I mean, like the prescriptions usually, like it varies from country to country, but and usually they go with, like, let's say here you guys go with 40 milligram pantoprazole twice daily.
In dysplastic patients,
yeah. In Sweden, for example, we go with esomeprazole quite often, but these as interchangeable as they are, their like potency is not really the same. Do you guys, like, if a patient is not, you expect, like, okay, this is not healing properly and I cannot assess, you bring the patient twice within 3 months interval, and pathologists cannot tell if this is dysplasia or whether it's still some inflammation. Do you double, like, to 120, like, or like 160 milligrams of pantoprazole?
It's a good question. My practical approach to managing the PPI in patients with Barrett's and dysplasia, because I think these are the patients where it's significant an issue. You can also, there's a subgroup, of course, with Barrett's, no dysplasia and inflammation. So I think key message one, do not tolerate inflammation in patients with Barrett's. Titrate the PPI to get rid completely of the inflammation and try and confirm that endoscopically. I think it's just important, because if a patient presents you with a 4 centimeter Barrett's who's inflamed, you should not accept that that patient is adequately treated until you have done a decent endoscopic assessment with no inflammation, right? So I think you have to titrate the PPI. I accept that there are differences, to which I'm not an expert, in the potency of different PPIs. But I do think that if you take your product that you're used to using and you titrate the dose, I'm often at 80 milligrams of pantoprazole twice a day to get control in Barrett's patients with a hiatus hernia. So there's also the concept also of mechanical control of reflux in patients with Barrett's, and that needs to be considered. It needs to be considered if you have, for example, a patient who you can't control their reflux with a product, you've tried a switch, you've added another, maybe ranitidine or not anymore, maybe famotidine or another product, then you need to consider mechanical therapy for controlling their reflux. Some patients don't want that. Some patients like medication, are happy with high doses of medication. Some patients don't want it or don't tolerate it. So I think both of them are complementary. Of course, you try medication first in the majority of cases. And then to your second part of your question, the dysplastic patients with very high doses, a lot of our Barrett's patients are taking very high doses and have required, for example, pantoprazole 80 milligrams twice a day to control their inflammation.